and welcome to this session about the economic value of speech and language therapy. My name is Amit Kulkarni and I work in the research team at the RCSLT, and I'm very pleased to be able to chair this session for you today. Just before we go into the presentations, I know you will have heard this many times before, but just in case, please do post questions for our presenters in the Q&A tab on the right-hand side of your screen. You can also leave comments in the chat, and please do also, if you have any, leave feedback. It's always great for presenters to hear about what your feelings were around the presentations. We're really excited to talk about this topic with you today. It's such an important topic for speech and language therapy. We really need clear economic data about the value of speech and language therapy services in order to support our profession. So we've got a sort of progression across the presentations today. We're going to kick off in a minute with Dr. Valerio Benedetto, who's going to give us an introduction to economic evaluation. We're then going to hear a bit more about the current research that exists around economic evaluations of speech therapy interventions. And then we're going to hear some reflections from a senior researcher who has had an economic evaluation arm within one of her projects. So I'll stop rambling and we'll get straight into these fantastic presentations that we have for you today. And I'm going to hand over to Valerio.
Thank you very much, Amit. As Amit was saying, I'm Valerio Benedetto. I'm a research fellow from the University of Lancashire, and I'm also a member of the Applied Research Collaboration Northwest Coast. What I'm going to give you today is a really brief introduction to economic evaluations in healthcare. I can probably speak about this for 3 hours, but I'm confined to 15 minutes, so I will try to give you the key information about economic evaluations. I'm going to start the presentation by showing you some quite controversial headlines, which I'm sure many of us have seen in newspapers or websites. These headlines will represent the emotions and also the difficulties in reaching certain decisions within the healthcare or the social care sector, of course. But what we need to focus on today, and what we can probably guess, is that decisions about funding certain interventions for healthcare services are based on rigorous decision-making processes, which are all about prioritization. So making sure that we use our resources wisely in the best possible ways. So prioritization, making sure we use the resource to achieve good value for money, is going to be the underlying pattern of my brief presentation today. Now, I'm going to give you some definition about economics, health economics, and then I will move on to health economic relations in a minute. There's hardly any math in this presentation, so you might be happy to hear that. And if you got any questions, of course, I'm happy to answer some of your queries later on. So economics is really about choice. So not only health economics, any economics discipline is really about choice. Choice between alternative options, which of course in the health area are alternative drugs, treatments, therapies, and so on. Why do we have to make these choices? And you might guess this is because we got limited resources. Here we talk about financial resources, but we can also think about human resources, of course. And specifically, health economics is the study that we look at the choice between different alternative uses of scarce resources available in the health sector. Now, in this graph, I'm going to try and portray the different concepts and at times issues we have to face within health economics, but also within a broader decision-making process in healthcare. So we know resources are limited, so we are dealing with scarcity. Scarcity is a key economic concept. Choices will need to be made. We got the problem of allocating our resources in the most efficient way. Efficiency, again, is another very key economic concept. But once we decide on how to allocate our resources, we are aware that we are giving up something. And that's true for any daily decision we make in our personal lives as well. We go to supermarket, we go to specific places, and we need to buy certain things, and we are giving up buying other items or other experiences and so on. So we need to be aware there is an opportunity cost, and I'm sure some of you will have heard of this term before. The opportunity cost is the cost of what we're giving up. Specifically, we can rank the different options according to their importance in our personal sphere or the healthcare sphere. And the opportunity cost will reflect the cost of the next highest valued alternative use of a specific resources. And the opportunity cost is a very central concept in economics, in general, in health economics more specifically. And I will try to describe how we use opportunity cost later on when I talk about economic evaluations. Now, this is a really simplified graph about the process behind an economic evaluation. And within an economic evaluation, we usually have to compare different alternative uses of a certain healthcare resources in this case. So we have a choice that we need to make between alternative A, for example, and alternative B, but there could be more and more alternatives that we need to consider. And each alternative will come with certain costs and consequences. And I think already at this stage, when we try to design and conceptualize economic evaluation, the input of a speech and language therapist will be very useful because they will be having an awareness of the alternative, the different comparators that might be relevant in a specific case or context. There are different types of economic evaluations there. I'm not going to cover all different types, but I'm going to focus on perhaps the two most common ones, and I'm sure you will have heard of these types of economic evaluations at least once. So I'm going to focus on cost effectiveness analysis and cost utility analysis. And they're all similar in the way they define and evaluate costs, but they differ in the way they estimate the benefits of specific healthcare intervention. It's important to note they're not mutually exclusive. So you can see papers, research articles based on and using different types of economic evaluations. Okay. So just to give you an indication of the differences between cost effectiveness and cost utility analysis, I'm going to focus more on the benefits. You can see already just looking at the cost column that, as you can expect, costs are going to be measured in monetary units. But there is a difference in the way we look at specific outcomes or consequences of an intervention between cost effectiveness and cost utility analysis. Now, cost effectiveness analysis will look at outcomes in natural units, so life years gained, disability days saved, points of blood pressure reduction. You got an example in the last column, which refers to a context of trying to find the most cost-effective intervention for hypertensive people, and in this case, it might be relevant to look, for example, at a reduction in blood pressure. For cost utility analysis, instead, we are looking at something a bit more composite in a way. We're looking at this concept of healthy years to measure outcomes. What do we mean with healthy years? It's typically trying to account for the quantity and the quality of life which patients experience as a result of receiving an intervention. So life years gains, but also associated quality of life. And this concept is associated to a very specific and very mainstream metrics, which is the quality exhausted life year or QALYs. When we look at economic evaluation, as I was mentioning before, we're looking at cost and consequences. So I'm going to focus a bit on cost now, and then I'm going to move on consequences in a minute. Total cost will refer to the costs which are related to all components of a specific interventions, and we can also look at specific total cost, for example, in association with the medications we need to use as part of an intervention, the staff time we need to use as part of an intervention, and other cost categories we might think that might be relevant. Total cost is it consists of two components, basically: resource use on one hand and unit cost on the other. At least on paper, it's quite simple to calculate total cost. You just need, ideally, to collect data on resource use, multiply this data by the relevant unit cost. And resource use is how many units of a certain item or activity you're going to need to use as part of an intervention. For example, if participants require to use or to have, for example, 5 tablets of specific medication, 5 is the key number here, is the resource use. Or they might need 3 sessions with a speech and language therapist, and 3 again is the number you're going to identify as relevant there. On the other hand, unit costs are the specific cost for one unit of a specific cost item. So 10 minutes consultation with a GP will cost X, 1 tablet of a specific medication will cost Y. And if you multiply these two components, you get total costs at the end. There are different types of costs, as you can imagine. We can collect direct medical costs, or we can try to find data on direct medical costs, so data related to medication, consultation, tests, and so on. Direct non-medical costs are broadly linked to the provision of healthcare, so things like travel, accommodation, food, and so on. Indirect costs are instead related to, for example, costs that might be incurred by patients or families and caregivers in terms of lost income or lost work days. And we can also think about externalities or other costs which might affect other sectors in the wider economy, like productivity losses as well. As we try to include more and more costs in our economic evaluation, we will embrace or adopt a wider perspective. And perspective is another of those key terms you will find virtually all times in economic evaluation papers. As a minimum, at least in the UK, we will need to consider the perspective of the healthcare system. So we will need to consider the costs and the benefits which are accrued within the health or the social care system. The data collection method for resource use are quite important, and this is again another activity where the input of speech and language therapists will be very relevant, especially when we try to collect patient questionnaires, diaries, which try to basically identify the resource use, or, for example, the number of visits in the last 3 months on the part of the participants, and trying to conceptualize and design these questionnaires is often a two-way activity between the health economists and the relevant clinicians, and we often have exchanges, interaction with clinicians in order to produce questionnaires which are easy to use and that do not constitute a burden to patients. All these first-hand methods are or should be validated and complemented by also looking at electronic health records, of course, or other pieces of information from literature, data sets, or guidelines. In terms of the outcomes, so we looked at cost. I'm going to focus a bit more on outcomes now. We talk about clinical effectiveness and composite outcomes. So clinical effectiveness outcomes will be relevant for cost effectiveness analysis. They measure how good the interventions are. And they're typically the primary outcome measures which will be selected as part of, for example, a randomized controlled trial. So cost effectiveness analysis, we need to remember this. They will try to calculate a cost per additional gain in health. And you can already see here we are trying to compare costs against outcomes. But ideally, the type of clinical effectiveness outcomes we would like to collect are long terms. I highlighted here some outcomes which might be relevant to speech and language therapy, like the pre-language school instrument. But there might be cases where we have to rely on surrogate intermediate outcomes, and you got some examples here. On the other hand, with cost utility analysis, we focus on composite outcomes. As I was saying before, we are trying to capture healthy years, so trying to quantify this concept of healthy years, which is linked to the estimation of quality adjusted life years or QALYs. And cost utility analysis will typically aim to calculate the cost per additional QALY. So if you think about it, quality is a specific type of health gain. So cost utility analysis represent a specific subtype of a cost effectiveness analysis at the end of the day. Why are qualis so mainstream? Well, one of the reasons is because they constitute a common currency across different health disease areas. They are based on generic health-related quality of life instrument, which could be applied and could have some relevance to different health or disease area, like speech and language therapy, diabetes, stroke, and cancer. But they're also based on preference and utilities, which if you know a bit about economics, you know that utilities are very, very important in any economic theory. So the fact that we are able to value particular health states as measured through, for example, the AQ5D is important in terms of formulating and trying to formally quantify qualis. So once we measure cost and outcomes, we are basically ending up in this cost effectiveness plane where we are trying to compare the costs and the effectiveness of the interventions, of the new interventions against usual care. And depending on the difference in cost and outcomes, we're going to end up in specific quadrants. Very often we're going to end up on the northeast quadrant where the new treatment is more effective but also more costly, because you might imagine it will bring some additional cost in terms of training or introducing a new type of drug or equipment and so on. So they often new treatments comes with a higher cost, but they also have a promise of being more effective. So this is the only formula I think I'm presenting today is about the incremental cost effectiveness ratio, where you can see formally the differences in cost and differences in effects between the different alternatives. Of course, effects are usually measured in qualis. So we are essentially trying to measure at the end of an economic evaluation the cost per additional quality. And the key question here is how much are we willing to pay for an additional quality? So we will have an idea in mind. Okay, I'm happy to pay a certain amount to gain an additional quality. At least in the UK, this maximum willingness to pay threshold is set between 20 and 30,000 pounds per quality, with some exceptions. So this is the end of my presentation, but if you're thinking of doing an economic evaluation and you want further guidance support, feel free to contact me, and this is my email address and the QR code to my university webpage. Thank you very much for your attention.
Thank you so much, Valerio. That was a fantastic introduction to what I know for many of us speech and language therapists is a really complex area, but such an important area. So it's great for us to better understand that area and work with health economists like you to create these valuations. Just to remind before we go into the next presentation, if you do have questions for any of our presenters, then please do put them in the Q&A. We're going to move now to our second presentation, where after that introduction, Dr. Lottie Metchard, Deborah Mole, and James Hill are going to talk to us about a scoping review that they carried out of economic evaluations of speech and language therapy. Over to you, Lottie.
I'm hoping everyone can see the slides. There they are. So there's going to be 3 of us presenting today. There was a large team of people involved in the study, and Debbie Mole will begin, and then you'll hear from Dr. James Hill, and then you'll hear from myself at the end. So I'll hand over to Debbie to start.
Hi, my name's Debbie, and together with Lottie and James, we'll be sharing about a scoping review of economic evaluations in speech and language therapy that was published earlier this year. Next slide, thank you. We worked as a team with members from RCSLT, UCLan, NHS trusts and universities, and the team involved clinicians, academics, and clinical academics. We have our next slide. So the evidence relating to economic evaluation of speech and language therapy hadn't been synthesized, and that meant that we didn't know the evidence that exists on the economic value or cost effectiveness of speech and language therapy. And it's really important that we understand this so that we can articulate and evidence it clearly to decision makers and to advocate for our profession. The next slide, please. So the aim of this review was to identify the extent and type of economic evaluations which are assessing the cost and cost effectiveness of speech and language therapy interventions. Next slide, please. And we aimed to understand what evidence exists at the moment, how well developed it is, so the quality and the quantity of that evidence, and the types of data that would be available to extract and use in future systematic reviews. I'm going to hand over to James.
Right. So methodologically, we went for kind of a broad approach. So we tried to include as many studies as possible to show you the breadth and depth of the evidence within the field. So we carried out a multi-database search to kind of try to get as much evidence as we can. And we set a very broad inclusion criteria. So the inclusion criteria was set to be any intervention, so any speech and language therapy intervention which assessed the cost. So as long as the study had cost data in, we would include it in our review to try to show the diversity and the kind of types of studies out there. This ended up with about 7,000 studies being identified, so these kind of wide strategies kind of resulted in a wide data set to then be screened and reviewed. Next slide. So from a coding perspective, what we wanted to do is to see obviously kind of what's been done and to what degree. So we coded it into kind of 5 study types. So the first study type was a cost description. So we use this as a broad term just to say that the study only reported the cost of the study. So they only reported the cost of the intervention with no additional data. So they didn't present any effectiveness data. They just described the overall cost of the intervention. Our next kind of layer down was a cost consequence analysis. So this is a study where they presented the cost and the effect, and they presented it in a cost consequence tree. So in a sense, they presented it with all the different options, with all the different decisions in regards to the different decisions of costs and the different degrees of the intervention, but didn't combine to create a utility or a cost ratio. The next level is kind of it's not a standard classification, but what we wanted to do is acknowledge in the literature where authors would propose that they were going to do a cost effectiveness evaluation, but didn't combine and create that kind of cost ratio. So for these studies, we call them a cost analysis. So it's not like a standardized term used across the literature, but we wanted to kind of highlight that there was a kind of a set of studies which stated that they were carrying out a cost effectiveness analysis evaluation, but what they weren't doing is that last step of creating that cost ratio. So we called this the cost analysis. And as Valerio has already highlighted before, the kind of gold standard or the kind of top level of evaluation which we were trying to look for is the combination of a cost effectiveness study. This is where they've combined the data together to create a cost ratio, and obviously a cost utility. So they've combined it and created it into a log ratio, created it into a standardized measurement tool which then can be used across other study types to compare. Next slide, and I'll pass you to Lottie now to discuss the findings of what we found in the review.
Thank you. So it probably won't surprise anybody that there was a huge amount of variation across the studies. So speech and language therapists work in a really wide range of different clinical areas. And so what we saw across the studies that were included were wide variation in clinical areas, wide variation in the different settings that were appearing across the different research studies. There was variation in mode of delivery, for example, face-to-face versus telehealth, or direct therapy versus indirect therapy where there's been training of other professionals. There was a wide variation in the specific interventions that were looked at. So as well as working across all these different clinical areas, I think it's also true that speech and language therapy, we also have a wide range of different possible interventions that we can use with the different populations that we serve. And then there was also variation in terms of the perspective of the costs, which Valerio summarized in his first talk. So where exactly the costs are being borne and how that's being counted. And then also variation in the time horizon. So were they looking just over the course of the intervention, or did they include a follow-up period, or did they also look at the time horizon and, for example, over the lifespan of the individuals that were going through the treatment? Of those 7,000 something studies that were initially identified, the final number that were included in the review, there were 52 studies. 44 of those were actually completed, and there were 8 protocols. So studies that were published as protocols or hadn't yet been completed. The good news is that the evidence is increasing and improving. So if you look at the graph down in the bottom left there, you'll see that from about 2012 onwards, there's an increased number of publications of studies, including some kind of cost analysis. And since 2019, 15 out of the 20 that were found that actually included the kind of highest level of evidence, so cost utility or cost effectiveness studies, most of those have been published since 2019. So this is getting better over time. I'll quickly go through the number of studies that we found in the different areas. This is just to highlight, again, what was found in the review, but also for those of you that might be interested in finding studies in your particular clinical area, you'll be able to go to the scoping review and find those studies that do include some kind of cost information, or hopefully a cost effectiveness or cost utility analysis. There were 26 studies within the adult populations, 17 studies within pediatric populations, and there was 1 study that had mixed across both. Within the adults, the highest number of studies were found within the area of stroke. So this was stroke aphasia, stroke dysphagia, sometimes both. Again, within those studies themselves, there was a high variation in what actually was looked at, or how the study was run and what was evaluated. There were a further 2 studies looking at interventions for aphasia, a further 2 looking at dysphagia, 4 in head and neck cancer, 3 for Parkinson's, and then a collection of studies across a number of different areas, for example, looking at respiratory conditions or traumatic brain injury. Coming into the pediatric literature, there were 6 studies that were looking at language and or communication difficulties, 2 studies looking at speech disorders, including cleft, 2 studies in pediatric dysphagia, 2 looking at social communication in autism, and again, a kind of final category where there was a wide variety in the clinical area, so for example, stammering or youth justice. So because of that wide variation, it wasn't possible to take a summary across all the different studies and produce a kind of final number to say, this is the value of speech and language therapy. In order to do that, you need a really robust evidence base. So you want lots of large-scale studies that are looking at similar things or the same thing. And you want them to be of high quality and using those cost-effectiveness designs that Valerio and James were talking about. So, for example, giving your outcomes in terms of QALYs. So you would want, for example, multiple studies looking at aphasia in stroke, carried out in particular contexts. You would want a specific intervention to be looked at, and that needs to have a protocol so that it can be replicated and you can get high fidelity for that intervention being delivered in the same way. You would want to be looking at similar dosages and measuring outcomes in a meaningful way that again links in with the cost effectiveness analysis. And you would ideally be measuring costs in a standardized way and looking at a societal perspective over a long time frame, over the lifetime of the individual, in order to really be able to demonstrate benefit and influence policy. One of the things that came out of the scoping review was that often the services, the evaluations that were done were looking at kind of speech therapy services rather than specific interventions. And in order for this data to become more robust and more useful, we need more research where they're evaluating specific interventions rather than a speech therapy service as a whole. So we've got many clinical areas, many different interventions in speech and language therapy, But the good news is that for a number of these, we actually already have data on the fact that those interventions are effective. So, for example, you can go to Cochrane reviews or other reviews in the literature that demonstrate the effectiveness of particular interventions within speech and language therapy. So a pragmatic approach from this point is to say, well, we know that these are particularly effective interventions, so now we can then analyse the cost of those interventions that we already know are clinically effective. The scoping review, it can be used as a reference point, so you can find those studies in your clinical area if you want to find, hopefully, cost effectiveness or cost utility information. In terms of those individuals working within the NHS, you can keep an eye out for any studies that are on the NIHR portfolio that might be in your area, get involved in those studies, and also push or ask about economic evaluation and whether that's part of what's happening in that particular study. From the point of view of the Royal College, it's aiming to support a system-wide push to further develop evidence in this area, increase the awareness of health economics in speech and language therapy. So, for example, in the last revising of the curriculum guidance, cost effectiveness and understanding economic evaluations is now part of the curriculum guidance within the research skills section, and to continue supporting standardised reporting, high quality intervention research in speech and language therapy. So just at the end here, I've put the contact for Dr. James Hill, who was the lead author on the review, and Amit Kulkarni at the Royal College if you have any questions about the scoping review. And that's it.
Thank you so much for that, Debbie, James and Lottie. After that introduction to economic evaluations from Valeria, it's great to get a bit more information about what robust economic evaluations actually exist within our profession. And just so everybody knows, the paper was published in our own journal, the International Journal of Language and Communication Disorders, and is open access. So you can access the paper there, or I'm sure we can put it in the response to Q&A afterwards. So we've heard a little bit about what economic evaluation is, about what exists within speech and language therapy, and now we're going to hear from Professor Pauline Frizzell, who's going to give us her reflections on leading a project which included an economic evaluation. So over to you, Pauline.
There we go. Sorry, I just couldn't find my mute button. Thanks, Amit. So yeah, just to say that this is a short presentation on a topic that I know is quite new and a bit complicated. So I have some additional slides in here that I won't discuss, but they're there for people's reference to have them. So this was the economic evaluation that we did as part of the Happy Talk pilot effectiveness trial. So this is a targeted selective speech, language and communication intervention, which is for children from areas of social disadvantage where we work with parents and early years educators simultaneously. It was a collaborative project between the researchers and the clinicians, and the analysis was led by our health economist, Dr. Aileen Murphy. So in this work, we wanted to, from the health economy point of view, we wanted to see what are the total costs and the costs per child of delivering the Happy Talk language intervention programme, and we took a healthcare perspective. We wanted to see, is Happy Talk cost effective based on language outcomes, and is it cost effective based on quality of life measures? And we wanted to see what's the uncertainty around the cost effectiveness decision, and is there value in collecting additional information? So this is called a value of information analysis, and I've left the slide in, but I don't have time to discuss it in detail today. So in order for me to have time to explain the economic evaluation, I'm not going to describe the intervention, but just to say that there is a parent training and a coaching component, and there is also a preschool training and coaching part of the intervention. So I just included those slides, as I said, for your reference. So in terms of our outcome measures, we had child, parent, and preschool outcomes. But here I'm just going to focus on the outcome measures that are relevant to the economic evaluation. So children's language was the primary outcome, and it was measured using the preschool language scale. which, as you know, is a standardized measure. It includes a receptive language score and an expressive language score and a composite total score. The secondary child outcome measure was the Child Health Utility Instrument. So Valerio referred to this, so the CHU9D. And this is a generic measure. It uses parent report, like it's a proxy kind of report scale, to measure health-related quality of life in young children. And so the CHU9D has about 11 questions, and parents are asked to base their responses on how their child is feeling on the day of completion. So it importantly allows for the calculation of QALYs. So this is an example of the measure here, and it also asks things like if your child is sad, in pain, tired, annoyed. It asks about schoolwork, it asks about sleep, their daily routine, and whether they can join in activities, and just in general how you would rate your child's health. So just as a reminder, the QALY is the number of years a person is expected to live multiplied by the quality of life value that's generated by the quality of life measure. So the QALY is what allows us to compare between the new and existing treatments to understand whether the new treatment brings additional QALY gain. So because we're basing our main cost effectiveness analysis on the child language outcomes, we need to know how much improvement was made on the PLS. And the total score improvement was what we used for our analysis. So you can see here a total improvement of 6.3 was the change in PLS5 total score. In terms of our economic evaluation costs, so what we included, so the costs of the intervention were measured using the standard national guidelines, so that we looked at the resources that were associated with the delivery of the intervention and the resources associated with standard care. So they were identified, they were measured, and then they were valued in euro. So only the direct costs of the intervention trial were included. So resources included personnel costs and materials. So the personnel costs included the costs of the SLT's time, including their tax and pension costs and accounting for overheads. And the SLT's time given also to the preparation, the implementation of the program, they were logged throughout the trial. All the materials and the printing costs were estimated at their current market rate at the time, and the therapist's travel costs were, so from place of work to the preschools was covered by a 25% overhead. In terms of what was excluded, although the trial included measurements at baseline and post-intervention, the cost of those measurements were common across the control and the intervention, and so they were excluded from the cost effectiveness analysis, and they wouldn't be part of an intervention. This was just because we were measuring it. It was assumed that in implementing usual activity, there were no additional costs incurred, and the cost of preschool staff's time was not accounted. And as the intervention costs were all incurred within 1 year, there was no discounting required. So to examine cost effectiveness, the incremental costs are compared to the incremental benefit. So in simple terms, the incremental cost is the extra cost of choosing one intervention over another. And I've just told you on the previous slide the costs that we included. So we know how that's measured. Then if we look at the incremental benefit, that's measured through our outcomes. So one was the additional point change in PLS5 total score, which you might remember was 6.3 for total language, and then in QALYs, which are generated from our quality of life measure. So if the intervention is more effective and is less costly than the comparator, then it's considered cost effective. So to help us determine this, we use the ICER, which Valerio explained earlier. So in simple terms, we look at the incremental cost divided by the incremental effects, so the benefits. So when you use QALYs as the outcome measure, as Valerio said, there's a nationally accepted cost effectiveness threshold. So it's called a ceiling ratio. So in the UK, that's between 20 and 30,000, as Valerio said. In Ireland, it's set at 45,000 euro. So in that sense, it's relatively easy to work out if something is cost effective. And this is basically, what is society willing to pay for a QALY increase? So if the ICER is less than the threshold, it can be considered cost effective. So in our case then, if the incremental costs divided by the effects are less than 45,000, then it could be considered to be cost effective. But we don't have that when it comes to language measures. So this is why the QALYs are great if we can have a measure that generates QALYs. But if we want to use language measures, so which is what Valerio referred to earlier as the natural units, then we don't know what society is willing to pay for an additional point change in PLS5 score. So instead we have to use some kind of a proxy measure to estimate what the monetary net benefit would be. So Marsh and colleagues found that for every pound invested in speech and language in the UK, it generates £6.43 through increased lifetime earnings. So this return on investment is 1 to 6.43, and that's applied to the cost effectiveness ratio so that we can estimate the expected monetary return. So this is compared to the cost of the intervention. So if the expected return is greater than the cost at this ratio, 6 to 1 roughly, it would be reasonable to say that society would be willing to pay that ceiling ratio for an additional point change in PLS5 score. So for completeness, I just wanted to acknowledge that our economic evaluation included a number of other analyses, but as I said, we don't have time to go into those in detail today. So in terms of our results, so the total cost of the intervention was €6,318, of which the personnel cost was the majority of that. So they covered 83%. So the cost per child then was €82.06. If we look at our cost effectiveness analysis, so the cost effective analysis demonstrates that Happy Talk is more expensive at €82 per child and more effective with an increase of 6.3 on the PLS5 standard score. So if you remember, our cost effectiveness ratio was the total cost divided by the total effect. And the cost effectiveness ratio then would work out to be just over €13. So €13 per unit change in PLS score. So using what they call cost effectiveness kind of acceptability curves, we can work out the probability that Happy Talk is cost effective. And we found that if society was willing to pay just over €28 or more for a 1-point improvement in PLS5 total, then Happy Talk would be more cost effective than the control. But as I said, we don't have a benchmark of what society is willing to pay, so we have to use this proxy from the literature. So if you remember, the cost effectiveness ratio is €13 per unit change, and the overall cost was €82.06 per child. So if we use this return on investment of roughly 6 to 1, then the expected return of an investment of €13.02 multiplied by 6 is 83, multiplied by 6.43, it works out at €83.75, which is greater than the cost of Happy Talk. So it would therefore be reasonable to infer that €13.02 for a 1-point improvement in PLS5 total score is value for money, and Happy Talk could be considered cost effective. If the effects are measured using QALYs, then we didn't get positive effects. So Happy Talk is more expensive than the control. We don't have an effect. So therefore, based on our quality of life measure, it's not cost effective. So based on our language measure, it is cost effective. Based using QALYs and a generic quality of life measure, it wasn't found to be cost effective. So in the field of education, an effect size of about 0.25 is accepted as a sufficient improvement to warrant changing our policy and our practice. However, this needs to be considered obviously within the context of cost. And given the reported Happy Talk effect size of 0.46, along with the fact that the programme appears to represent value for money, then our findings add to the evidence suggesting that a targeted selective public health approach could reduce the societal burden of children with low levels of speech, language and communication. However, we obviously need longer term outcomes and a much larger trial to be more definitive with respect to kind of policy changes. So that's what we're currently doing. We're currently doing a large randomized control trial in which there is an economic evaluation built in. The gold standard for economic evaluations are cost utility analysis, where the outcomes are measured in terms of QALYs. This is the secondary analysis presented here, and it shows that when outcomes are measured using CHU9D, Happy Talk would not be considered cost effective. But underlying these results are the differences in the effectiveness measures, which make QALYs for this population cohort and intervention. So also noting that our intervention was quite short. So I suppose the point here being that some of the things that are being asked about on these generic measures are not things that we would expect to see change. So these kind of quality of life constructs would not be expected to change necessarily with language improvements. Some would, but some wouldn't, particularly in the short term. There are measures designed specifically for communicative domains that, like, for young children, like, for example, the focus on the outcomes of communication under 6 is a lovely functional measure. But whether a suitable algorithm can be developed to map focus to a utility measure so that a QALY estimate can be generated needs further research. And in the absence of reliable utility data to estimate QALYs, we measured our effectiveness, as I said, in natural units. So just to my final slide, we acknowledge that there are some challenges here and indeed limitations associated with the analysis presented here. For example, our sample size was quite small, it was a pilot trial, and we had short-term follow-up in the trial. And certainly the sensitivity of the health-related quality of life measures to what we are expecting to see change in is an issue. Also, we employed the perspective of the publicly funded health and social care system in Ireland. So we excluded parent costs. So that could be considered quite a narrow approach. However, the choice of perspective was guided by the national HIQA guidelines. We definitely need further investigations into how improvements in language score can be generalized into more functional improvements so that we can get QALY gain so that that's warranted. And certainly there's a priority for larger scale evaluations with longer term follow-ups to examine if the language improvements persist, but also to determine if there's an impact on health-related quality of life over a longer period. So as I said, that's currently what we're working on in a randomized control trial. And this is the paper that I've just been in with, describes the study that I've just been speaking about, and thank you very much.
Thank you so much, Pauline. That's great to hear your reflections as a researcher who's had an health economics arm to the research that they've carried out, and will be interesting for everyone, but hopefully particularly for researchers who are attending this session. Thankfully, we've got a little bit of time for a live Q&A at the end. There'll also be an opportunity for us to answer questions via the platform if we don't get to them within this Q&A session. I'm just looking at the Q&A that's come through, and I think a clear theme emerging is we want, as speech and language therapists, to understand economic evaluation a bit better. Books that exist in this area, training courses, glossaries. I wonder if I could come to you, Valerio, first, just to say, if as speech therapists we're interested in learning more about this area, where are some good places to go to?
That's a really good question. There are several places, but I would strongly suggest to go and have a look at the York Health Economics Consortium website. So I can send you links afterwards.
Brilliant.
They have a brilliant glossary of health economic terms. I regularly consult that and just for my own use to prepare teaching material. There are also several short courses available from different universities. I got a link to a list of these short courses, so I can forward that on. In terms of books, again, the vast choice, but there's a book called Introduction to Health Economics by Guinness and Wiseman, so Lorna Guinness and Virginia Wiseman. And again, that could be a very good, introduction to this field. And if you want suggestion for a bit more advanced books, I can also send you some information. Another good place is the Office for Health Economics website as well. So you can find a lot of resources there. Blogs as well, where things are explained a bit in a easier way, let's say, with simplified examples. So yeah, again, I'm happy to forward some links afterwards.
Fantastic. Thank you for that. So we'll definitely forward on any links that you send to us so that attendees have all of those. I wonder if I could come to others on the panel as well. I know that for the team that did the scoping review, which I was part of, this territory was very new to us. And I think, Deborah, you in particular have said that this is a really interesting further step to develop your exploration in this area. Did you have any reflections? Because I know lots of people listening may well be new to this territory, but certainly from our point of view, it was fantastic having you as a kind of fully functioning part of the team.
Yeah, it was completely new to me, and I felt perhaps a little bit out of my depth at the beginning. But I really enjoyed it. It was really interesting to take that step out to something completely different for me. I'm a speech and language therapist, but working in research delivery. There was a lot of support available. I've learned a lot, and learning from those different sort of academics and clinicians really helped me to get a bit more of a broader overview of this area, which is really important. Yeah, I would really encourage people to get involved in these projects and find out more through RCSLT.
Thank you. Yes, I think it's for us as a profession to really take this forward. It was great in the scoping review, finding that this has accelerated within the profession. There are more economic evaluations going on. They're of better quality as well. So that's all pointing in the right direction. But I think the onus is on all of us to continue that push and also to utilize that data within our services. Pauline, I wonder if I could just ask you actually, what do you have any particular reflections about the impact of having that health economics arm to your research?
Well, if I could just say first to tell people not to be afraid of it, but to speak to a health economist, because I knew nothing about economic evaluations before we started ours, but I worked with the health economist who explained things to me. And really, from a speech and language point of view, you just want to know at the start, what data do I need to collect? Like, what do I need to make sure that I have? And sometimes it can be quite simple to collect it, but it can be hard to collect it after the fact. Whereas if you know at the outset, well, I need to know the cost of this and I need to be logging that. And so I need to know exactly what I have to log so that our costs are being, and when I started as well, I thought, but we'll have to include the costs of the parents. And, obviously there are different approaches, but these are the guidelines that you take the perspective from the healthcare provider, for the one that we did. So I suppose you're unlikely to be conducting the actual analysis in the end. So I don't think you have to be an absolute expert. You just need to know what is it that I need to collect in order to drive it forward.
Exactly. And yeah, and have those collaborations, I'm guessing, with those health economists around you.
I suppose the other reflection I have is just that it is, we're crying out for a measure that we can use that represents functional change within our field, that then can be converted into some kind of utility measure that will give us qualities, basically, so that, because some of the questions are just so generic, and we know that we're not expecting change. Sometimes it can be even about whether there was a change in someone's hearing or a change in their vision, or and we know we're not expecting changes in those. So it would be great if we could have a functional measure that we could have some kind of algorithm that would be able to work with that so that it could generate qualities.
Yeah, so important. And just from that impact point of view, I know that, let's say for our RCSLT policy team, it's been, what they really need in order to champion the value of SLT services, in government and other levels is this information. And I know Professor Beverly Harden in her talk earlier today was talking about the need for data like this in order to turn commissioners' heads. We've recently seen the release of the AHP policy research priorities, where economic evaluations has come out very highly within that as well. So we know we need this information. We know we need data of all sorts, but this will speak to commissioners. So great that you and others can be collecting this for us. I wanted to launch into some of the other questions, particularly the ones around the MDT. I saw some interest in that, but I'm very aware of time, and apologies, I don't think we'll be able to look into those now. But just to say thank you so much to everyone for attending. I hope it was provided some level of gentleness to the introduction, as well as some insight into the overall landscape within speech therapy, and then those more detailed reflections from Pauline. Thank you so much to all of the presenters for presenting your fantastic work to us. I'm just going to wrap up by saying that firstly, in terms of the Q&A, we will try to address some of those via the platform afterwards. And then secondly, this elusive secret code that comes at the end, so you can earn your points for the reward area, I think will come onto the screen in a minute. So thank you so much for that, and look forward to further sessions on this another time.